Good afternoon, folks who are just now joining. We'll commence with our seminar shortly as the numbers of participants gets to the usual expectation. So we're just building up now. Hang on one second, we'll start. Okay, good afternoon, everyone. Welcome to the Berman Institute of Bioethics bi-weekly seminar. Really excited today to have as our guest speaker, Saad Omer from Yale University. And before I turn it over to my colleague Ruth Faden to make the introduction of Professor Omer, I just want to say we're getting close to the end of our spring series, so we'll obviously let everyone know when we're about to take summer hiatus, but keep track of the calendar at bioethics.jhu.edu, and we look forward to seeing everybody again in 2 weeks. So with that very short welcome, let me ask my colleague and good friend Ruth Faden to introduce our speaker for today. Ruth.
Thanks, Jeff. It's really my great pleasure to introduce another dear friend and colleague, Dr. Saad Omer. Dr. Omer is the inaugural director of Yale's Institute for Global Health. He is also at Yale Professor of Medicine of Infectious Disease at the School of Medicine there, and he is the Susan Dwight Bliss Professor of Epidemiology of Microbial Diseases, that's what it is, at Yale School of Public Health. So if I were to go through all of Saad's honors and accomplishments, and you hear this all the time with introductions, but it's really true. It would take a very, very big bite out of the short time that we have to hear from Dr. Omer. So let me just summarize it by saying he's an internationally acclaimed leader in the epidemiology and prevention of infectious diseases, in vaccine research and development, in vaccine acceptance, and in vaccine and infectious disease policy. Of particular relevance to the Berman Institute community, Dr. Omer is also a leader in ethics and infectious disease policy. In the current pandemic, he has been a major contributor to the resolution of ethical challenges, both nationally and globally. Dr. Omer served on the National Academies of Medicine Committee that produced the landmark report, a framework for equitable allocation of vaccine for the novel coronavirus. He currently serves with me and other wonderful colleagues on the WHO SAGE working group on COVID-19 vaccines and vaccinations, as well as on a number of other WHO COVID and pandemic-related advisory committees. It has been my distinct pleasure to co-lead with Saad the drafting of two key WHO SAGE documents, the WHO Values Framework for the Allocation and Prioritization of COVID-19 Vaccination, and the SAGE Roadmap for prioritizing uses of COVID-19 vaccines in the context of limited supply. What we need are shorter titles for these documents. It would help a lot. So I did want to sort of share with everybody that Dr. Omer, in addition to all of his accomplishments in infectious disease broadly, is also very much a major contributor to the ethics of infectious disease, and in particular in the context of this pandemic with regard to vaccine policy. But in addition, I wanted to highlight for our whole community that Saad is one of our own. He completed his medical training at Aga Khan University Medical College in Karachi, but then he came to Hopkins, where he did both his MPH and his PhD in global disease epidemiology at the School of Public Health. I asked Saad if there was anything he wanted me to, in particular, highlight as he's coming back to, I'll just call it his home institution, the institution where he began his career in public health. And he said, although he can say this for himself, that he was happy to relay that he's always grateful for getting the best training in public health. I'm going to add that you could get. So with that, Saad, welcome back to Hopkins. I know you've come many times since you've left, but it's just a delight personally to have you hosted by the Berman Institute. And with that, we'll turn the program over to you.
Great, it's my pleasure to be here. It's always good to visit Baltimore and East Baltimore and Hopkins although this time the visit is virtual. And I was telling Ruth, I got an excuse to wear my Hopkins tie. And just a disclaimer, I'm not a card-carrying ethicist. It's just that I paid attention in my ethics classes during my PhD and my training here there at Hopkins. So and learned a lot during that period, and have been using some of the stuff that I sort of learned, frankly, and sort of that started a journey of combining infectious disease science and policy with some of the ethical foundations, because they are not sort of naturally different silos. We actually, the way the disciplines are often taught and structured and incentives are there, they're artificially separated, but it's very instinctive to combine your graduate school training, which is supposed to be interdisciplinary and includes ethics, with a lot of thinking around infectious disease policy. With that, I will share my slides. I'm assuming folks can see my slides. So I'll be talking about equitable allocation of COVID-19 vaccine in an inherently unfair pandemic and an unfair world. One of my pet peeves was when people would say that the virus doesn't discriminate. It absolutely discriminates. It finds the most vulnerable groups and impacts them disproportionately. And that is true in terms of within country equity and global equity. So I'll start with a few thoughts so I'll be covering a few things. I'll cover some of the allocation efforts that I've been involved with, some of the global equity aspects, and then some messaging around it. Because one of the biggest inequity in this pandemic is the inequity of information that folks have at various levels. So I had the privilege of being part of the National Academies of Sciences, Engineering, and Medicine framework for equitable allocation for COVID-19 vaccine. For me, a lot of this stuff happened in parallel with the WHO working group that Ruth described, that I've had the privilege of serving and waking up for many days a week for several months, and I have the privilege of serving with Ruth on. But starting with this, we were charged by the CDC and NIH director to come up with an overall framework, not the nitty-gritty sort of individual level recommendations, but the overall framework and provide the rationale for that. So this was before all the discussions and a lot of the debates around who should get it first, second, whether we should target hotspots, and these days the biggest barrier between a brainwave, no matter how cogent the output of that brainwave is or not, or how appropriate or well-grounded the output is, and the main barrier between that and something being taken seriously is a New York Times op-ed editor. Before that discussion, we were tasked with this effort, and we came up with the framework, and that said that we had two dual goals. One is to reduce morbidity and mortality, and then reduce negative societal impact. And there was a lot of confusion and discussion about, and both domestically and globally at that time, that we should, because the social life was being disrupted substantially in terms of how do we reduce the negative societal impact. And we said that both of these goals are important, but the sequencing of it might need some nuance. And we developed this risk-based criteria, and we said that to bring some method to this madness, we should look at 4 risks: risk of acquiring infection, risk of severe morbidity and mortality, and risk of negative societal impact, and risk of transmitting infection to others. And then we said that based on these risks, we have to consider the fact, and at that time there were a lot of alternative proposals being floated about sort of targeting the young first because of the year of because of their interruption in terms of their life expectancy and all of that stuff, and very well-meaning, very well thought out efforts were afoot at that time. But we looked at the epidemiological data, and we could not look away from the drastic inequity, the drastic heterogeneity, and the risk of mortality between groups, especially based on age. So compared to the 18 to 29 years old, even 65 to 74-year-olds had 90 times higher risk of mortality. Later, Ruth, myself, and Matt Crane, sort of a medical student at Hopkins, added more nuance to it in an op-ed in Washington Post. But overall, it was very apparent that age was a huge factor in determining the risk, overall risk of mortality. The other thing we said that, look, initially we will have restricted vaccine supply. Eventually, everyone should get this vaccine. But when you have limited vaccine supply, you should prioritize reduction in mortality first, even before societal impact. And there were several reasons for this. Death is irreversible. And there is social consensus on preventing severe morbidity and mortality. And for interruption of transmission, you need a critical mass of people vaccinated. So you will lose that time period where you could have directly prevented death and disease and severe disease by trying to interrupt transmission with the very first dose given. And the other thing is, at that time, trials were not designed to assess impact on transmission. Since then, there's been a lot of evidence of these trials, evidence that these vaccines that we are using interrupt transmission or reduce transmission. And there was limited transmission data on risk groups, that who's giving it to whom. Yes, broadly we knew essential workers were there, were important, but we did not have quantifiable criteria. Based on that, we said that whatever you look at, you should prioritize mortality and first, and then go to negative societal impact. We also said that social vulnerability is important, and this is an unequal pandemic, and the fact that it is exacerbating the racial bias in the structural racial bias in our health system. But we also wanted to highlight that there's more than one social determinant of health, and the fact that they are just a simple race-based prioritization may be challenged in courts for various reasons, especially in the current legal environment. So because of all of that, we proposed, so the National Academies were the first entity to say, look, you prioritize based on the risk of severe morbidity and mortality first, and increasingly go to interruption of transmission, and go to entities like teachers, etc., for resumption of normal social function. But you, within those, make sure the access is ensured through social vulnerability index. And this is based on 15 census tract variables, includes race, income, first language being English in a census tract, or it can be computed at the county level as well, crowding, and age 65 or older. So these are determinants that were fairly relevant to what we were looking at in terms of this pandemic. And so that was the other thing we recommended. And it is, as I said, can be calculated easily. So based on that, I would say, without going into the specific categorization in the interest of time, you saw that the first groups were almost as it is adapted, which was we recommended healthcare workers and those living in long-term care facility. We had smaller groups than what CDC ended up having, and that reflected in the fact that states adapted a more targeted approach, and then quickly going to resumption of normal function, overlapping with the rest of the elderly, etc. So there was a lot of mishmash in terms of messaging, etc. But at the end of the day, when we looked at that informally with Ruth and Matt, that I'll talk about in a second, not in terms of details, at least initially, the first initial priority groups followed this overall approach that was reflected in CDC. The part that was reflected in the CDC's guidance was taken, that passed through CDC's guidance and states directly adapting this model was as it is. The thing that was different in CDC, that they wanted to prioritize essential workers first in terms of their articulation of equity, that actually didn't get translated into states domestically in the US. But moving to the global work, I just want to acknowledge in terms of the work that I've been doing as part of WHO SAGE Working Group on COVID-19 vaccine. We have been a team, a mini team within that with Ruth and Matt Crane, who's a Hopkins medical student and is working with Ruth and myself. So just to give you a big picture, so COVAX facility, a lot of people have heard of. Within this WHO Strategic Advisory Group of experts, there was effort to say, even before vaccines became available, how do you signal to countries to get ready for prioritizing this vaccine when the supply is limited? So we started with the values framework, in the group, where the articulation was of the principles, the ethical principles that should go into this kind of country's own thinking. Then we translated into the prioritization roadmap, and then we are now doing vaccine-specific recommendations. COVAX had an overall allocation framework that initially came out with that sought feedback from various groups at SAGE, but was an initial sort of independent entity, but it did sort of have, we did have a crosstalk with this. So in the values framework, there were 6 core principles. So human well-being, global equity. So at the very beginning, and what we said, what the document said, that we acknowledged that countries have a responsibility and perhaps a right to look after their own population. But that sort of right and responsibility is not absolute. They also have, or exclusive in terms of responsibility. It is also to other countries. So this is late summer, early fall that we are talking about this, preempting some of these issues that you're saying. We also had articulated reciprocity. And reciprocity was very limited formulation of reciprocity, or framing of reciprocity in this case. We tried to restrict abuse. For example, Bill Gates investing in vaccines doesn't automatically make him eligible to receive vaccines before anyone else. But we're talking about healthcare workers who had taken the initiative and had borne the, a disproportionate burden of morbidity and mortality, or even without that in situations of risk. Then we had equal respect. In addition to that, we had national equity. The idea was that these, we often talk about, often the thinking is that when we're talking about domestic work, we are looking at domestic inequities. And when we're talking about global work, we are looking at between country inequity. But if you really want to do global health, you have to acknowledge that there are inequalities within countries. One of the lessons I learned when I started in what is now called global health at the age of 19 in Pakistan, the first communities we started working in, one of the biggest lessons was that not everyone was poor at the same level. There were gradations of poverty even amongst the very poor. There were power structures. And sometimes the differences, minimal differences in wealth mattered, had an outsized impact on power structures in these communities. So national equity is equally important, and the legitimacy of the process is very, very important. So these decisions should not be corrupt. They should not have a process that is not transparent. It can be imperfect, but it has to be transparent. So this is what we did. We had these principles, and as a group, we had well-being, equal respect, global equity, national equity, reciprocity, and legitimacy. And then we translated them to actual objectives. Some of them were overall, but often these objectives translated to actual priority groups. So keeping that in mind, but I wish I'd had time to go into a lot more detail of this process. We moved to a prioritization roadmap. And the idea was to support country planning. The roadmap suggested public health strategies and target priority groups for different levels of vaccine availability in various countries. And the consensus was that, look, there were a lot of things. This is before vaccine data became available. This was before, the Mondays in late fall or early winter, where every Monday there was a vaccine phase 3 trial press release. Without knowing that, we said that, of course, this will be modified based based on when the vaccine data become available. We also said that, look, a one size cannot fit all. And so therefore, we have to consider what is going on in a community. So a solution for Vietnam or New Zealand might not be the same for India and the United States. And I'll come to that in a second. And then vaccine supply scenarios. This is dynamic. And based on these two things, you have to clarify an overall public health strategy. So often what happens is that you articulate these principles, you articulate, what are the inputs, et cetera, how much vaccine is available, and have scenarios, but you don't explicitly say, what is your strategy? Are you interrupting transmission? Are you reducing mortality? Are you resuming, you're preventing the disease to disease importations, et cetera? So we thought it was important to be crystal clear and encourage countries to be crystal clear in terms of their overall public health strategy. And so the scenarios we had were community transmission. This is India, this is the US, and situations where there's sporadic cases or clusters of cases. There are many countries where the vaccine, there are regions where there's transmission going on, but not nationally. And then there's a situation, places like China, Vietnam, New Zealand, and Australia, et cetera, where they have controlled this outbreak based on their non-pharmaceutical interventions. So you can't have exactly the same solution for them if there are no current cases. But on the other hand, they remain vulnerable to importations, et cetera. So in terms of the public health strategy for community transmission, the idea was the initial focus on direct reduction, again, that may sound familiar, of morbidity and mortality, but also maintenance of most critical essential services, as well as reciprocity as framed for healthcare workers. Then, as vaccine supply becomes available, expand to reduction in transmission to further reduce disruption of economic functions. So that was the strategy we articulated for those with community transmission. I will quickly pass over this one. The sporadic cases was similar, but regional focus. But the big contrast was with no cases. When you don't have any cases for transmission, cases of or indigenous transmission of this disease happening in your country. So what the focus could be here in terms of public health strategy is to prevent prevention of community transmission. So block the virus to coming in, but also reciprocity here in terms of healthcare workers, because they don't have a current high risk, but in terms of transmission risk, but they are taking risks and had been part of the proactive response. Then, as vaccines become available, expand to preserve control of transmission, then reduce reliance on the most burdensome non-pharmaceutical interventions. Even if these countries are successful, there's a burden of these non-pharmaceutical interventions. And as supplies become available, take out an insurance policy on the very highest risk individuals in the event of importation associated outbreak. So once you have sort of strengthened your fortress, make sure you further put an armor on the most vulnerable inside your sort of inside the four walls of your, or five walls, whatever, of your fortress. So these were the scenarios that we assumed. Stage one was approximately 10%, and we further categorized them in 1A and B to give options to countries. Stage two, 11 to 20%, and stage three, 21 to 50%. So based on this, the community transmission scenario was stage one were healthcare workers at high to very high risk. So we pegged this to some of the International Labor Organization definitions of who is at high to very high risk. It's not the hospital CEO, but folks that are working in those situations. And we explicitly said that it shouldn't be a function of your diploma. It should be a function of what your exposure is and your risk is. The second thing is older adults defined by age-based country-specific criteria. We explicitly said that each country has their own appropriate cutoffs. Then moving on to that, older adults not covered in stage one. So that was important. And then individuals with comorbidities health states determined to be at significantly higher risk of severe disease and death, sociodemographic groups that are at a higher risk, health workers engaged in immunization delivery, and high priority teachers and staff. So making sure we wouldn't have, in certain countries, the education workforce is so big that you can't do that, the whole workforce in this group, but we said that it would be best to have some high priority groups. For example, there was a view that the consequences of disruption in elementary school education are more durable, and so they are more irreversible. So maybe prioritizing there or by risk scenario. And then in stage 3, you had a focus on pregnant women, other essential workers. Now, based on this evidence, I would think that some countries would hope. At that time, the evidence was emerging that pregnant women would be a bit earlier in this group. So this gives you an idea, without going through each and every group, what the approach was. In terms of no cases, we started with health workers at high to very high risk, but then talking about essential travelers at risk for acquiring infection outside, border protection staff, emergency reserve utilization for focused outbreak response. So that was the idea, that you preserve your gains from interruption. Then second one was health workers at low to moderate risk of acquiring and transmitting infection. Then all travelers at risk of acquiring infection outside the home country. And then again, emergency reserve of utilization for outbreak mitigation, not just response. And then there's more overlap in stage 3 of no cases, older adults that are at high risk, so that you're taking out an insurance policy. And then talking about teachers, et cetera, because in a lot of these countries, the schools were already open, and some of the essential workers outside the health and education sectors. We emphasize national equity considerations, that countries should ensure that prioritization within countries takes into account vulnerabilities, risks, and need of groups who, because of underlying social, ethnic, geographic, or biomedical factors, are at risk of experiencing greater burdens from the COVID-19 pandemic. There's a special group that earlier on we think about is in terms of these determinations, and one of them is pregnant women. So this is some earlier work we had done, and I know Berman Institute and others have done a lot of work in pregnancy, but so some of the work in our group had thought of it in terms of risk and benefit worth in mothers and infants. That's actually the conventional way of thinking it. So when we started working on it after H1N1, we said that ethics of maternal vaccination require a slightly different treatment. Because if you ask women who do they want to protect, often the biggest consideration was their baby, even if they had at a higher risk themselves. So we have empirical data from the US and outside to support that. I'm not showing it in the interest of time. So we said at that time that when you are thinking about formulating policy for pregnant women, there should be legitimacy of a mother's interest in the welfare of her fetus and infant. That's, it's a legitimate interest. You're not just saying, you can't be paternalistic about making the decision for the women. And we said that this interest-based approach should have specific characteristics. First of all, a mother's agency should be front and center. And then the other part is inclusion of women in decision-making. And there's a reason why a lot of us are against panels, male-only panels and male-only committees, and we have had, very good people that I have a lot of respect have written on maternal immunization recommendations without having a single woman author in that. And it wasn't nefarious. It's just that these kinds of, who is not in the room often is also as important than who is represented in the author list, because these kinds of interest-based approaches should account for, at various levels, women's participation, and either both through data but also individual participations in these kinds of things. But we also said there should be limits on options for mandatory maternal immunization, because this is why it is different from childhood immunization. So having said that, there is, when these vaccines came out, there was a lot of consternation, et cetera. But the bottom line is most of the recommendations and eventually WHO recommendations also converged on that, were based on providing the opportunity to have access to these vaccines to mothers, and had mothers' agency front and center. I'm not saying that this directly informed that, but what I'm saying is that this kind of a framework is in line with the thinking that happened eventually around this vaccine for pregnant women. Now thinking about COVAX, the facility that was, the entity that was created by WHO, CEPI, which is the Coalition for Epidemic Preparedness Innovation, Gavi, which is now called Gavi, the Vaccine Alliance. It's no more an acronym. It used to be Global Alliance for Vaccines and Immunization. But essentially, 3-4 entities coming together said that we can't have a situation where low-income countries do not have any access to vaccines. And so last year, they created this entity called COVAX Vaccine Initiative. And that says that there were countries that were participants, and then subsidized countries. So this was in early January. That was the status around January or late last year. I forgot the exact date of the number of countries. And you can see that a lot of countries were relying on COVAX. And even large countries like India and Pakistan were relying on COVAX as subsidized access, and some of the other countries were relying on COVAX as combined access. What happened was, it was a sort of a game theory kind of a problem, in the sense that one after another, people got freaked out by others making deals, and this cycle got exacerbated. And there was and there remains a huge threat to COVAX because of those side deals. But on top of that, these were the projections again from January, as of January 20th, of how many COVAX facility vaccines should be available, especially for low LMICs. And at that time, by April, you were looking at 235 million doses. Right now, the number is a little over approximately, the exact numbers are not available. It's in the vicinity of 40 million doses right now. So we are behind in this in terms of COVAX. The kinds of vaccines that are there, this begins to tell you the story of why it is the case. So Oxford AstraZeneca, for all of COVAX and no COVAX, was the most sort of frequently subscribed vaccine. And after that, Pfizer, et cetera, but mainly, the AstraZeneca vaccine, Oxford AstraZeneca vaccine, was the main one. And a lot of it was the reliance on the Serum Institute of India. And there were, because even before this recent surge, there was these restrictions on India exporting these vaccines to other countries who were relying and are relying on these vaccines being available in their countries. And this is from this morning. Right now the situation is, in certain countries, in Namibia, home of 2.5 million people, only 128 people had received two doses of vaccines as of mid-April. And this is a country, and this is what the president is saying, that we did the right thing. We filled out all the paperwork, paid their deposit, so it showed that their skin is in the game, but they haven't received the doses. And it is because of those restrictions, because of the fact, partially because of the fact that when these plans were being made, the big player within that, the US, was absent from these discussions. So the plans were a little, from my subjective perspective, were less ambitious as they could have been if a country with the biggest checkbook and the most access to this kind of IP were at the table. So right now in certain countries, the situation is that they're likely to have more photos of vaccines arriving at the airport than actual people vaccinated. And so often you see these in Twitter feeds that the vaccine has arrived in this country and that country, but the reality is that we are in a vaccine-free world. And I'll talk about some of the behavioral aspects of vaccines because they're important in this context as well. But we often, in vaccines, we do not think the concept of behavioral inhibition happens too frequently, meaning that you change your behavior because you've just gotten the vaccine. Because we have empirically examined it for HPV and so on and so forth. But this might be different, both at the individual level, setting that aside. But I think that what happened was countries like India got taken in by their own photos and politicians getting the vaccine. And they thought that that's it. Now the vaccine is here, and then we are going to scale that up. Right now, less than 1% of India's population is vaccinated. And the country has had religious festivals with millions of people there, political rallies, etc. So I think we need to be careful in our messaging in terms of, while we demonstrate that it is reaching to the countries, but it should be in line with how much vaccine is actually getting administered to people. We did this work late last fall, and others have done it similarly. So we paired up with economists and other colleagues at Yale and Bocconi in Italy, who basically said that looking at US travel patterns and other data, we created this network model, and we said that very quickly after a certain threshold, the best use of a US vaccine is to actually administer it to an LMIC country. And it is in our interest, this is not even taken into account, the variants, etc. It is in our interest to not aim for a perfect 100% vaccination coverage, but to have a dynamic system that as we work on that, we make an effort to increase vaccine coverage in other countries as well. So now switching to what is happening in terms of vaccine distribution, et cetera, and how many people are getting vaccinated in this country. The projected, so New York Times has had a graph a few weeks ago that will be used in a few demography and epi classes going forward. They drew a straight line and said that by June 27, based on what was the coverage at that time, 78% of US adults will be vaccinated. Well, that's not how life works. As the initial group got vaccinated, you had a situation where, so this is in a more nuanced analysis, Sergo Ventures asked these questions and said that adults who want to get vaccinated immediately might do so by April 2021. So you get 46% two-dose coverage and 59% full coverage. And then, or sort of 46% two coverage and 59% at least one dose coverage. And you will get to a plateau very quickly. I don't know if the figure will be the same, but we are looking at a scenario where there was a huge high demand in one sector, but then there are a lot of people who are lukewarm about it. This is from this morning. And in terms of those who did not get the vaccine, and so this is at least one dose of vaccines that approximates the coverage, only 18% are saying that they will definitely get it. And so these are the data that are concerning. But also in terms of who will definitely not get it, the biggest chunk is conservative leaning 18 to 40-year-olds. So we can't let this go. We cannot have a situation when this is the natural state of things. We need to have evidence-based approaches to communicate, not hunch-based approaches. So when the outbreak started, so this is a brief story of vaccine acceptance work that we have been doing. With one case, this was Jan 23, 2020, I asked the question in the New York Times, is America ready for another outbreak? Because the signs were already bad. I wasn't predicting a pandemic, but I said that based on the fact that it was introduced fairly early and it was pretty obvious it was just the tip of the outbreak, tip of the iceberg, I said that in order to have this kind of a response, let scientists lead because it enhances confidence in your response. No false assurances. We fell into that trap earlier on because there is data from communications research that initially anxiety goes down in the public, but eventually it backfires. The other thing is that there will be, I predicted at that time, this was January 2020, that there will be new sources of scientific and public misinformation. There will not only be outright disinformation, but there will be half-baked assessment. People will exaggerate. And what we were looking at that time was the fact that there was preprints were becoming more popular, and without peer review, people will jump to conclusions, etc. Unfortunately, these things were prescient. On February 8th, 2020, more than a year ago, we wanted to see who should lead the response. And we had the director of the CDC. This was before Tony Fauci was a household name. Essentially, the public was saying that it should be a scientist-led response. The other thing is, what were the best information sources? People said CDC, NIH, but also healthcare professionals. And in this pandemic, we haven't empowered healthcare professionals to communicate this message of trust in vaccines. We also found, this was in May 2020, we found that there's likely to be high heterogeneity in vaccine acceptance in the US, and we created this predictive model. This was also published in one of the journals that said that these are the factors that you can that can predict vaccine hesitancy in the US with reasonable but not perfect reliability. And some of these groups you have been hearing about in the news. Now, in terms of vaccine hesitancy, just to remind everyone, it's a spectrum. There are very few people who refuse all, but it is a larger group than we had hoped for. But a lot of these people are in the vaccine hesitancy group, a lot who wanted to, or fence sitters who wanted to wait and see. But that group is shrinking. What created a misperception that people with in the active demand part of the spectrum were expressing their desire to get this vaccine very, very proactively. So people thought that there's so much demand that if you open it up, people will come, and that didn't happen, and that does, a lot of us were concerned about this. So therefore, we started working on approaches with my colleagues in political science and economics. We started working on different interventions. So this started in late summer 2020 on what would be the policy levers to enhance confidence. And we did this randomized experiment where we said that what would be compared to vaccine approval 1 week after the election, what would be the confidence and uptake if the vaccine was approved before the election, a week before the election or December. And it turned out a December approval was more favorable for confidence. The picture was not that clear for uptake. So doing this correctly after the election calendar did have benefits. The other thing we did was vaccine endorsement and vaccine acceptance by different so-called elite endorsers. Positive statement whether they believe in this vaccine versus negative statement whether they don't. But essentially, Tony Fauci's endorsement did play a role and was going to play a role. So this was before the vaccine was approved. We also said that it would be a muddle if political leaders like Trump and Pelosi had different messages, and we want them to speak with one voice to have sustainable coverage. We also did a few messages in large trials, and the messages that worked in terms of vaccine acceptance was a non-bravery message. So you're not brave if you don't get COVID vaccine, takers in terms of that moved people's attitudes and anticipated behavior. Community interest. Getting the COVID vaccine reduces the risk of spreading the disease to community and loved ones. But then we combined with this behavioral thing that said, from other literature, we said, in addition to community interest, if you said, imagine how embarrassed you will be if you don't get the COVID vaccine and you spread it to the others. So this is a strong medicine. It's not for every message, but it can be used in nuanced messages. We also talked about mandates back in July, but we essentially said that you have to meet 6 conditions. It should be recommended, it should be available, it should be inadequate response before you consider mandates. There are a few things that we have developed, vaccine misinformation management guides that I will quickly show you, and that has these tools for risk categorization, etc., when to act and when not to act, how to respond to misinformation directly. You start with the fact, you warn, you outline the fallacy, and then respond with the fact without going into details. Essentially, what I want to convey is that there are these tools available. And one of the things that I want to talk about is values-based messages. So just like taste buds that give us permutations of flavors and people have differential underlying sensitivity, social psychologists have been talking about moral foundations, that all of us have these 6 moral taste buds, but they are differentially triggered in different populations. So they are care harm, fairness cheating, loyalty betrayal, authority subversion, purity degradation, and liberty oppression. A few years ago, we wanted to figure out whether vaccine decisions were moral decisions. And so we said that what happens to hesitancy in people who emphasize these values differentially? Are they more pro or against vaccines, or whether their hesitancy is low or high? Turns out their hesitancy is low if they emphasize authority. But their hesitancy is high if they emphasize purity as well as liberty. So both of these things, but especially liberty-based messaging is the new thing we are doing, especially for the groups that I highlighted, the newer groups, not the newer groups, but the groups that are emerging as the having the biggest gap in terms of vaccine acceptance. So we have a vaccine messaging guide. We developed another broader guide as part of the WHO Behavioral Insights Technical Advisory Group that goes beyond messaging. And then we're working on this 5-country project with Facebook of evidence-based interaction. And we're doing trials at the country level to look at vaccine coverage district by district, province by province, based on this messaging. So I'll pause here and would be happy to take questions. But we have a few minutes for those, for a lot of questions. Or at least some questions.
Yeah, thanks very much, Saad, for that really interesting, obviously timely presentation. We do have some time for questions, and I see we have one in the Q&A that I'll raise for you. Others are welcome to just please post any questions you might have, and we'll bring them out in the time remaining. So the first question, actually, it's interesting you mentioned preprints. It relates to one of your own preprints. But more broadly, it looks like the question is about this kind of ongoing discussion around 1 dose versus 2 doses and the pros and cons and trade-offs there, and whether you see any indication for or arguments for allocating vaccines globally in a way that would allow for more people to get 1 dose, for example. So your thoughts on that, I think, would be appreciated.
So a couple of things. In the US especially, so I started with a very neutral approach, and Ruth knows that that we had sort of really early off background discussions that the data that the companies were presenting based on their cutoffs was underestimating 1 dose efficacy around this, and sort of I was of the view that we should consider it. But as the data emerged, and sort of you're talking about our preprint, so this is just to remind everyone, so this is the first one to evaluate 1 versus 2 dose on mortality, because that's, again, I'm hung up on mortality. At the end of the day, it's about saving lives in a pandemic. And the other things is hospitalizations, etc. The Israel study, which was very nicely done, looked at any vaccination, did not differentiate between 1 or 2 doses. We are finding that even with 1 dose, there's pretty high efficacy against mortality, but you do get perceptible jump in protection. You get to 99% protection if you have if you have 2 dose, the full 2 dose schedule. So I think from the US perspective, what it does make sense it does make sense to have a 2-dose schedule where the vaccine is available. Here's the reason why. If we were in a world where there was an equal situation where even without vaccinated giving the full schedule, it will be distributed throughout the world, that would have more nuance, but that's not going to happen in the US. And in that kind of a situation, I think it was reasonable to stick to a 2-dose schedule, because I'll give you an example for mortality. It's 64% protection against death with 1 dose only, which is great, which is wonderful. But there's still, you get to 99 or 100%, so 34, 35 percentage point increase in protection against death with the 2nd dose. So that's a big deal. So it depends on how what sort of metric you're using. Globally, in the WHO recommendations, we were more nuanced. We said countries could, the clinical schedule is still 2 doses based on the vaccine. And we're getting data from other places like Chile, et cetera, that some of the other vaccines that are being used, like Chinese vaccines, the protection is even lower with one dose. And there is gap in data. I think there are other interventions for this based on the evidence, not a preconceived notion. I was very sympathetic to a 1-dose idea. Based on the current evidence, I think there are other ways we should insist on ensuring equity than a 1-dose schedule. And then the variant issue is another one. You may be in a situation where it's not that you're going to increase the number of variants due to partial immunity. That argument may not hold based on some of the modeling work that has come out, but just the fact that you may not be able to prevent the increase of variants.
Thank you. Hopefully that addressed your question. If not, please feel free to follow up. So we have another question here about vaccine passports and your opinion on that in relation to the issues here. Thanks.
So again, my problem is, I don't like them intuitively, but I think we'll have to, whether or not we like them or not. Well, it's a strong statement to say I don't like them. It's just that my position has been that whether we like or not them or not, they're coming. And we should not waste time in pushing back against whether the passport is a sort of a loose word. The incentives are such that countries and entities will go in that direction. Our efforts, our best bet is to make them as equitable as possible, as efficient as possible, and as effective as possible in situations where they're warranted. I'll give you an example. How do you ask someone, the Saudi government to shut down the Hajj the 2nd time? They did that. This was unprecedented. But there are people around the world, rich and poor, who save a ton of money. They have to do it once in a lifetime. And how do you allow people from all around the world without a proof of vaccination? How do you ask a small business owner to either put everyone at risk or to have some requirement for their indoor, for example, if it's a jazz bar where the ambiance is part of the business model, how do you ask them not to have the option of checking who is vaccinated or not? On the other hand, this should not be used gratuitously. It should not disadvantage, it should not be imposed in situations where access is not guaranteed, etc. So it should not be, another way for privilege to be exacerbated. So it depends on the situation, it depends on the location, and it has to be then as efficient as possible. Unfortunately, they are here to stay because the incentives are so big. And we are likely to be in a situation in this country where people who are vaccinated come this fall will be protected. But because of huge pockets of vulnerability, we will continue to see outbreaks of this disease. So the overall numbers will come down, but we will hear about these outbreaks. And so in those situations, it becomes tricky, and the incentives, and how do you expect colleges to open up again? And so we can advocate, and against them all around. But when the rubber meets the road, people who are teaching in classrooms would want to see these things being implemented in their own colleges, in their own classrooms. And so these kinds of situations, and if you impose them for students, what about the staff? And so these are tough questions. I don't have all these answers, but despite a lot of discomfort with the negatives of these, the incentives are so huge for various entities that unfortunately we'll have to learn to live with them, but try to make them as equitable and efficient as possible.
Thanks. We have time for maybe one or two more questions. Maybe I'll raise one and then see if others come in the chat, or if my colleagues Ruth or Jeff would like to raise any themselves. But I was curious about the discussions that happened around, I guess what you were sort of characterizing as putting morbidity and mortality at the forefront, and in relation to the issues of also honoring reciprocity. I was curious if any discussions were had in the work groups around, others who are perhaps at high risk of exposure, like factory workers and others who, are thought of sometimes as essential to maintaining, the health of the population through nutrition or whatever it might be, and sort of where they fit in the mix in terms of both fulfilling a sort of social function, but also obviously the risk for morbidity, mortality, and spread and all of that.
So here's the thing: if you compared head to head a mortality in a grocery worker with a 65-year-old, a 65-year-old has a higher underlying risk of mortality. And this is not theoretical data, this is empirical data, if you look at that. On the other hand, there is a higher risk of transmission in those workers. So where they fit in the very next group, so when we're talking about essential workers in terms of the WHO framework, they were not in stage 1, but they were in stage 2 or 3. So they were prioritized, but not as much, because we said that there were other groups that had legitimate claims to prioritization, especially in the NASEM framework. There are other legitimate claims to prioritization, but mortality is irreversible, etc. And so that is, so that brought some clarity to a little bit of our thinking. And then the risk-based criteria actually did have, these essential workers gave them a pretty high score.
Yeah, I was actually thinking in relation to that.
I'm sorry.
I was actually thinking in relation to the prioritizing healthcare workers specifically, as individuals who often have other kinds of protections in place, PPE, et cetera, right? Comparatively, yeah.
So what we looked at was that even in terms of when you look at the actual risk, so there was I think a Human Rights Watch report, PPE was not universally available in the, throughout the world. So that was one thing. There we threaded the needle by saying that not all healthcare workers should be eligible. We said that we had specific criteria based on ILO prioritization of what is your exposure. So it's not everyone. It was a very limited group of people who were engaged with really high risk procedures and often without a lot of reliable protection. So that's what the thinking was.
I see, thanks.
And then there was the other part of it is that we needed to, what really scares me about India, for example, are the second order effects of what is happening in terms of the massive disruption of the healthcare system. We know that we had some of these effects in the US and we'll continue to have those disruption in healthcare. But in India, a place like India, it will be way worse.
Great, thanks. Ruth, maybe I'll just ask you if there's anything you want to say as in closing or questions you want to leave the group with.
We've got 2 minutes, so I think maybe the best thing we ended the hour promptly, right?
That's right. Yeah.
So I'm more inclined to just say thank you to Saad. There's so much that you covered. It was a real tour de force of vaccine ethics policy, from R&D through to acceptance, through to mandates, and now ending with passports. So I think we've done a lot, except to say thank you, Saad. And I'm guessing that that's what Jeff wants to add as well, but I will leave room for that. So thank you so much, Saad, for this.
I would just add my thanks to you, Saad. So much information and depth. We really appreciate your being with us today. Just to remind everybody that we have one more seminar coming up on May the 10th, which is Malia Fullerton from the University of Washington. Saad, you want last word?
Yeah, so I just want to say that, a lot of work that I had presented was, collaborative work, et cetera, and especially when we work on these reports and committees, et cetera, it's the committee staff that sort of carries a lot of sort of burden of sort of bringing the ideas together, but also contributing to ideas, et cetera. And so I couldn't name everyone, but it is indeed, when this kind of stuff happened, it's group effort. On the WHO side, it was the WHO staff, Secretariat staff. On the NASM side, it was the NASM staff, and some folks may be familiar to this group within that staff. But overall, a lot of it, heavy lifting, is done by those groups.
Thanks for saying that, and I'll pass that pat on the back on to Ben. So thanks everybody. Thanks Saad so much, and we'll see you all in 2 weeks' time. Have a great afternoon.
Great.